And the final session of the day is entitled Managing Eye Care in APS Type 1. And so I'd like to invite David Seyfert as a parent and Dr. Asim Ali from the University of Toronto to take their seats on the podium. So David, I understand you want about 7 minutes to speak, 7 to 10 minutes? We don't need a timekeeper. And then Ali can follow you.
Dr. Ali can, yes. And somebody keep time for him because he's got a shuttle to catch at 4:15. So we want to know by 4:10? Sure. Okay. Thanks, Pat. I'm a teacher of the visually impaired and an orientation mobility instructor. So I know I've run into quite a few kids with visual impairments. So it was kind of ironic that the first sign that my son had was he became very photophobic. One day he walked outside and said, "It's too bright, I can't see." So we took him to our pediatrician at the time, and he examined him and said, "I think he's doing it for attention." So that was the last time we saw that pediatrician. I walked right out of the office. I knew a bunch of pediatric ophthalmologists, so I took him right to immediately to one of the pediatric ophthalmologist's office. He took us in, and he said, "I can't even examine him. He's so light sensitive," and he had to had to force his eyes open to be able to examine him. He said there's some kind of corneal something going on. I don't know what it is. I'm going to refer you to a corneal specialist. I'm going to start treating it with steroid eye drops. And that relieved it. And then we went to see a corneal specialist at Stony Brook, and he said, "I don't know what it is." One of my students had 5 corneal transplants, and his mother said, "You need to see somebody up in Westchester that we use." We went up there, he examined him, and he said it's viral. It's either Epstein-Barr, Lyme's disease, or herpes simplex virus. So we had Matt tested, and it came back positive for Epstein-Barr virus. So the original diagnosis was immunokeratitis from Epstein-Barr virus. He said he wouldn't treat it. He would stop these steroid eye drops. And I said, "Well, why?" "Well, you can develop cataracts, or you can develop glaucoma. Glaucoma is very dangerous, and it's very difficult to check for glaucoma in children." And that didn't seem right to me. So my father-in-law down in Virginia found a pediatric corneal specialist. We went down to see her, and she said, "Why wouldn't you, give him steroid eye drops to reduce the inflammation in his eye?" And we said, "Well, glaucoma." She goes, "You can always check for glaucoma. Let me see if I can check him now." And I took a tonometer out, and she checked his eye pressure right away, no problem. So we left the doctor in Westchester, started to have Matt Sini down in Virginia. We would travel down every 3 months down to Virginia to have regular exams. And by a year later, Matt had been identified as an APS type 1 person. And the doctor down in Virginia said, "Well, it doesn't look like the usual eye condition that's associated with APS. It really looks like Epstein-Barr virus. They look different. And what will happen is eventually he'll stop fighting it, or his body will learn how to fight it, and he won't show any symptoms." So Matty was asymptomatic about 5 years later. So we stopped. She said, "I'll see you in a year." Well, 4 months later, I just happened to look at Matt, and he had a large infiltration, a large red spot on his eye. I almost had a heart attack. So at that time, it was like we couldn't just drop everything, go down to Virginia. We went to a local ophthalmologist who happens to be the person who trained Dr. Ali. And the first thing he said to me, he goes, "I can follow your ophthalmologist lead down in Virginia. I can lead. I can collaborate with her. Whatever you need, that's what I'll do." So I knew right then and there he was my guy, because he was going to do whatever was best for Matthew. So we transitioned Matthew over to Dr. Michael Connors down the road. And it took us about 5 months to resolve this infiltration in Matt's eye. His vision, which had been perfect, changed a little bit in the eye that had the infiltration. He went to about 20/40. But then once we got the infiltration resolved, we spent the next year, I'd take Matt every month, and we titrated down the amount of steroid he needed. We found the lowest dose steroid the fewest times that we could manage, given that Matthew sometimes is going to be compliant, sometimes not. So we didn't get to the bare minimum, but we got to what would be a minimum that Matthew could manage if he missed a drop here or missed a drop there. So everything really, we were pretty stable for about 7 years, and last November Matt developed Sjogren's-like syndrome. So his eyes were very dry. We start to go to Dr. Connors every 2 weeks to kind of see what we could do to manage it. We added Zebra to Tobradex ST and Restasis, and the Zebra didn't really seem to help. We tried mucus plugs to block up the tears, to make the tears drip more slowly and stay on the eye a little bit longer. That didn't work. So then we went to Boston Sight Foundation, and we got Boston Pros lenses, which are a lens that holds fluid in them. It's a scleral lens. It's a big lens. It takes quite a bit of training to kind of get used to, but it does provide protection for the eye and keeps the eye moist. So, you know, here we are 11 years out, or 13 years out, and we've really been able to preserve Matt's vision so that with his Boston lens in, his vision's 20/20, and he does very well. So it's just been something that, you know, has taken a lot of conversation back and forth with the ophthalmologist, you know, and a lot of staying on top of it, a lot of conversation. So it's something that we've been able to manage. I know it's not always that easy, but, you know, I think there are steps that Dr. Ali can go into. So thank you.
Thank you. So thank you to the organizing committee for inviting me. I have to say, after listening to David's story, I might have been one of the first few people he saw, because the very first patient I ever examined with APS, I didn't make the diagnosis. The eye problems preceded everything else. Of course, once I knew what it was, I learned a lot in a hurry, and I've taken care of a few more since then. And one of the things I'm going to do is sort of go over a little bit more about the eye, a little bit of basics, because even amongst practicing physicians, what eye problems are, people sort of think it's all one thing, and there's really different parts, and they have different implications. And one of the interesting things about APS, or difficult, I guess, on the other side of it, is that it can present in so many different ways. There is no sort of typical APS situation. Everyone's very different, and I think I've been fortunate to hear such good presentations today which tell you that there's so many different ways it can manifest. I'm a pediatric ophthalmologist, and I'm a cornea specialist as well, so I have interest in the dry part of it, but we're going to go much beyond that in our discussions today. So the eye has a certain distinct structure, and in front of the colored part of the eye is the cornea, and we'll be talking a lot about that. And the purpose of the cornea is to bend light and to be transparent, but also protect the inside of the eye from the outside world, so it's very, very sensitive. And then in the inside of the eye, you know, there's the lens. The lens helps focus light, and the retina lines the inside of the eye, and that's the light sensing part of the eye. So these are sort of basic things. And of course, whenever you have light coming in, anything that blocks the path of the light, be it in the cornea, be it in the lens, can affect your vision. And also, of course, if the retina is not functioning, that can also affect your eyesight. So how can APS affect the eye? The very first mention of a dry eye in an APS patient was actually 1943 in another article. So this is not new information at all. And in fact, in 1962, there was an article specifically on eye problems in APS written by an ophthalmologist. So we're over 50 years now where there's been some discussion of this problem. And what happens is that the immune system targets different parts of the eye, and that's why I'm going to talk about all the different parts of the eye. And there's a wide range of effects, there's a wide range of severity, and it doesn't seem to be proportional to the effects on the other body parts. So, you know, if you have a specific problem with Addison's, it doesn't seem to correlate with what part of the eye is affected. Sometimes the eye is the first organ that's affected by the disease, and sometimes it happens later on. Sometimes the eye is not affected at all. Now, these are all the ways in which APS can affect the eye. These are the most common ways. In fact, there's more than this that's been described. So cataract is one of them. Ocular surface disease, which is tears, and the external surface of the eye, which is very important for dry eye disease. You can also end up with corneal scars, which can block the vision. You can also get inflammation inside the eyes, which is called uveitis, and that's sort of in the front of the eye and also at the back of the eye, sort of in the middle there. And then the retina can be affected also, and that can affect your ability to sense and process light. Now, this is a complicated slide, but it's important to talk about where tears come from and what this concept of the ocular surface is. And this is really a whole area almost within ophthalmology itself, because so many conditions can affect your tear production, and they can be very debilitating. You have your tears that are produced by your lacrimal gland that sits on the upper outer side underneath your brow there. And that's your main gland, but you have actually a whole bunch of other smaller glands that are affected also. And the tears go from the outside, they drain over the surface of the eye, and then they go into this series of ducts and tubules down into your nose. And the reason this is important is that one of the ways you can treat dry eyes is by blocking the system over here, and those are called punctal plugs. It's like just putting a stopper in the drain, and then you can allow the sink to fill up. If you're, and then the sink is really over here. And in APS, one of the biggest problems is the lacrimal gland doesn't function as well. So the tears also have, purpose. They protect the eye. There's antibiotics in your tears. They lubricate the surface of the eye, and they also help with vision. In fact, when light hits your eye, the first surface that it hits is your tear film. So if your tear film isn't nice and smooth and regular, your vision is also affected. And tears have more than just liquid in them. Tears are salty, but they also have lipid, they have fat in them. The fat prevents evaporation, sort of coats the surface like oil on the surface of water. The actual liquid component, which is the biggest component of tears, includes antibiotics, which is lysozyme, includes nutrients, it has hormones as well, and it's affected by your hormones and your nerves. And then there's also a layer of mucus, which is made by the cells we call goblet cells in the conjunctiva, and they allow it to spread normally and wet the surface. So if you think about it, this is a cross-section here, and this is your cornea, this is the front of the eye, this is your eyelid, and these are your eyelashes here. There's a space between your eyelid and the front of your eye, and extends. It doesn't go all the way back, it just stops up here. But this entire surface is lined by different membranes, conjunctiva, and there are glands, there's lacrimal glands that produce fluid, there's goblet cells, and then in your eyelid there's these oil-producing glands called meibomian glands. So this is actually quite a complicated system. As you blink, it redistributes the tears. And when you lose a component of your tears for whatever reason, your eyes can become very, very dry. You can get irritated as well. So the range of symptoms can start with just mild irritation up to severe pain. And if your eyes are extremely dry, you have a lot of difficulty even opening up your eyes. You become very, very light sensitive. And the front of your eye is very, very sensitive. It's one of the most densely innervated parts of your body. So if you've ever had a scratch, those of you who have ever had a scratch in your eye will know how painful that is. And that's because of all these nerve endings that are there to protect you. And so if you do get something in your eye, your eyes will water copiously so that you don't get any kind of damage. People describe it in different ways. Grittiness, we call foreign body sensation, the feeling that something's in there. And then if your eyes are dry enough, your vision also decreases. So it can have a big effect on quality of life. Now I'm just going to talk a little bit about the cornea also. In David's story, he talked about having a spot on the cornea, and really the cornea should be completely transparent. It's designed to be that way. And it's transparent for a number of reasons. It's organized. There's no blood vessels in the cornea. It's one of the parts of the body that has no blood vessels at all. And it actually has very few cells, relatively speaking. But it does have different nerves. And it has an organized and layered structure. And this surface at the top here, which is what's relevant, is called the epithelium. It's the area on the outside, and if that ever gets scratched or dry, that's what causes the pain. So I'm going to talk first about really the cornea and dry eye and APS type 1, because that's really the most common thing that's been described. And the other things are less common. And depending on the study or the paper that you read, it's between 25 and 50% of patients have some degree of involvement of the cornea. And the variety of involvement that you see can vary a lot. So this is an eye, and you can see there's a little line over here. Okay, you have a little bit of sort of scarring, but the eye itself is not red. And then you can compare that to this here. And you can see that there's scarring everywhere. You can see the pupil is blocked. So I would expect this patient has decreased vision. And the other thing to observe is you can see there's a blood vessel growing here. And there should be no blood vessels on the front of the cornea. It should be perfectly crystal clear. And when you do get blood vessels, it's a sign that there's been some inflammation before, there's been some damage, and the blood vessels can leak or they can contribute to scarring as well. And there's really wide variety of ways in which the cornea can be affected in APS. And these are some more severe cases from another paper. And you can see, this sort of these deposits at the sides and at the edges of the cornea, as for example over here, sometimes in the center. And then you can see something like this. In fact, this is somebody who's had corneal transplants, and the corneal transplants have become cloudy, and because of the same process that's going on. This picture just shows how dry the eye is. This is a green dye, orange dye that turns green with light. And that these little dots that you see everywhere are signs of extremely dry eyes. It should be completely smooth. And the other thing that happens is if you do get some scarring in the cornea, it's not that it just blocks the light. A lot of those pictures you can actually see through. And what you see is that as light gets in, it scatters. So it just sort of goes everywhere. And this is, I describe this as having the feeling of driving into the sun with a dirty windscreen. Your eyes have, you glare, you want to close your eyes because the light kind of scatters everywhere. It also reduces your ability to see, especially in bright lights. So in addition to everything else, this can also occur. So how do you treat this? I'll go over the medical treatment. So the sort of the basic first line is to, you can treat with tears. Depending on the severity. If the eye's inflamed, that's not going to be enough, and I'm going to talk a little bit about that. But if it's only dry eye and there's no signs of inflammation, you can treat with tears, you can treat with these punctal plugs, and that's sort of your very, very basic treatment, and that's not going to treat any kind of severe case. Most of the time, people who have APS will have an inflammatory stage. They'll come in and they'll have these spots on the eyes, and those need to be treated with some sort of anti-inflammatory drop. Most ophthalmologists will use steroids of different kinds. As David mentioned, there's side effects to steroids, and they have to be monitored, but they are sort of your basic 101 first step technique to sort of control the inflammation. If you need long-term use of these medications, you do run the risk of high pressure inside the eye, which is glaucoma or cataracts. This can all be caused by steroids. And often you can use two other medications. You can use cyclosporin. Cyclosporin is known as Restasis in its lowest dose. It's available throughout North America. Or you can use a higher concentration of cyclosporin, which has a stronger anti-inflammatory effect. The advantage of using any of those cyclosporin is that you don't have these side effects from the steroids. Tacrolimus is another drug. If you look at both cyclosporin and tacrolimus, they're used for example, after kidney transplant to handle rejection. But in the doses that you're using in the eye, they don't really have an effect on the rest of the body. There's a recent paper that has come out on the use of tacrolimus drops in people with APS out of Saudi Arabia, in which they showed some control, but not complete control of the inflammation. So if you were to catch the cornea being inflamed earlier on, you want to go through the stage where you use these medications because the less dry the eye is left, the more comfortable you will be down the road. You can use basic things like humidity control. If you live in a very dry house, in a dry neighborhood, in dry climate, you can treat that in the house. You can use goggles. And the next step up is to use, and what was mentioned, either contact lenses or the PROS device. Now this is just a regular hard contact lens. You wouldn't normally use it for dry eye, but the reason I'm showing it, you can see it here, and it's more for reference, is it also does something else. This is a scan of the front of the eye that shows this is the contact lens sitting over this cornea. And the reason I'm showing it is that you can see that the surface of this cornea is kind of irregular. It thins out here, there's some scarring. But the contact lens kind of smooths out the surface. So the contact lens can give you a new front surface of the eye, and it can improve the vision, and it can also provide some protection. Now the PROS lens is a much larger contact lens. And you can see here, this boy doesn't have APS, by the way, but he's got a much larger lens. You're only seeing the bottom here, so it's really going all the way up till here. And this is in both eyes. The white that you see is just where it sits, but that's normal. And in the cross-section, you can see that this lens actually doesn't sit directly on the cornea. You can see there's a space here. And it's like a fluid bandage that sits right on top of the eye. And the lens is designed such that there's exchange of oxygen and nutrients through that, so the eye is protected that way. So having it larger and having less movement is also more comfortable. What I find is there's difficulty and there's some skill involved in trying to put it in the first time. Actually, in the audience is Dr. Deb Jacobs, who's the medical director for the Boston Foundation for Sight, where this patient, this particular patient is gone, but also the patient that I take care of who has APS. And the results have been very good in terms of quality of life because you don't have this constant drying on the surface of the eye. It also calms things down. It also regularizes the epithelium. And overall, even without the lenses, I think the quality of life improves. What do you do when you have something like this? So, contact lenses won't necessarily fix really, really cloudy eyes that have all these blood vessels there. And then we're into the realm of surgical treatment. Now, unfortunately, people have tried different things where, for example, if you say scrape away that scar tissue, which you can do, that hasn't helped because it grows right back. People have done corneal transplants where they will remove the central part of the cornea and take a donated cornea and stitch that in. And again, the problem has been is that many of those fail. Those blood vessels that shouldn't be there can cause the transplant to be rejected, and sometimes this cloudiness you see can grow back into the transplant. There's some thoughts that some of this failure that you're seeing on the surface is due to a failure of the stem cells that heal the front of the eye, and it's been described, stem cell transplant's been described. Now this is very similar, it's not like a corneal transplant, this is very similar to having, say, a kidney or something replaced. You have to be on very high doses of immune rejection drugs for about 2 years afterwards. And so there's been about, I think, 2 or 3 cases of this that have been reported. And I'm not sure this is applicable to everybody. It's quite a significant step. And the other thing that's been reported is what's called keratoprosthesis, which is an artificial or plastic cornea in these situations, which can't be rejected, but has its own problems, including a high risk of infection. And I personally don't recommend that in children. We've had some very poor results with that, but it has been reported in adults as being another alternative. Many authors and myself recommend conservative treatment first, just because the risk of complications seems to be much higher in people who have APS. And this is that same picture I showed you earlier. This is an eye after 3 transplants, and you can see that white clouding kind of keeps growing on top of it each time, and it doesn't seem to go away. I'll talk about a few other things. Inflammation or uveitis. In fact, it's not seen that commonly. It's a bit, for something, an autoimmune disease, we don't see much uveitis at all. It can cause pain and vision loss and scarring on the inside of the eye. And this is much more typical to what we see in people who have, for example, juvenile arthritis or other conditions. And the treatment for this is steroids or non-steroid immunosuppressant drugs. Methotrexate's one of them, and there are others as well. Again, this has been mostly in small reports, and really, apart from a handful of cases, isn't seen very often. And what does a cataract do? Well, cataract is any time the lens becomes cloudy, and the cataract can block the light getting into the rest of the eye. And cataract in APS is thought to be due to the low calcium that's seen that causes a cataract on the side. And it doesn't seem to cause vision loss all the time, although there are times when the lens can become cloudy enough to require removal. If it's significant, it's actually one of the easier things to treat from an ophthalmologist standpoint. You can have cataract surgery with a lens implant done, and the success rate for that seems to be no different than anyone else. The involvement of the retina is probably the second most common eye problem in APS. The retina, remember, senses the light that comes into the eye, and the function appears to be affected. And when you have the retina function affected, especially, it seems to affect what's called the rod cells, which are, there's rods and cones in your retina. The cones sense bright light and color, and the rods are better in dim vision and in your peripheral vision. So if your rods are affected, you have reduced night vision, you have reduced peripheral vision, and in some cases, if it's severe enough, you get reduced central vision. We had looked at a number of patients, and we published on this about 2 years ago. And I'm sorry, it's not showing very well, but I'm just going to point out to you here. It's probably easiest to see these little black. This is what your optic nerve looks like, and all the blood vessels are normal at the back of the eye. So what you see here are these little black spots, which are actually pigment clumps, and those are signs that the retina itself is starting to degenerate in those areas. And what happens is you end up getting tunnel vision, you have trouble at the dark, and in fact, in the patients we looked at, a number of them actually had trouble in their central vision as well. And we had patients who were 20/20, and we had patients who had very decreased vision because of the retina. An electroretinogram is like an EKG. So it measures the electrical activity of your retina, and that's a test that you can do to screen for this in case you don't see these changes earlier on. The problem is that, of course, if you have very dry eye, you're light sensitive, it's very difficult to do an electroretinogram. It can be done under anesthetic, though, and we do that often in our institute. The other thing which was interesting, the patients we looked at, a number of the patients had what are called anti-retinal antibodies. These are actually quite rare. APS is one of the few things this will do this. The other thing is cancer. We know that basically the immune system was attacking the retina, which is why we saw these changes. But the other thing was that there was no improvement with immunosuppression. So putting high doses of immunosuppressants didn't seem to stop this from happening. And again, sorry this doesn't project, but there's these same sort of things here where there's pigment clumps and there's cross sections through the retina. This is like a CAT scan of your retina. It shows that the retina thins out over here and here, and that tells us why the function is not so good. So I'm just going to end up here. There's just go over some of the major points from my presentation. So there are a wide range of presentations of eye diseases in APS type 1, and this really is very broad, at least for ophthalmology. I've covered a lot of ground and a lot of subspecialties and a lot of different things that people may not see. And this may be the reason why there's some delay, at least from the ophthalmologist standpoint, because of this wide variety of presentations. The most common thing that's affected is the cornea, and then the retina after that, and then everything else is distant third and beyond. I'd recommend non-surgical techniques to treat the dry eye as much as possible, be it drops, anti-inflammatories, punctal plugs, or I do recommend the PROS-LED device as well. If you can get an electrogram, it's helpful. It's not something that you can necessarily treat, but it's good to know how much function is impaired due to the retina versus how much is there because of the surface or scarring. It gives you an idea of what's going on. Okay, thank you very much.
Thank you, Dr. Ali. Do you know exactly where the limousine is going to be? I can walk out there later
Sure.
if you want.
Yeah, I can take a few minutes. We can
So we have a few minutes. We can ask some questions.
Thank you very much for joining us today, and I know you have to get back quickly. I have a couple of questions about the PROS lenses.
Yes.
How big are they? Are they hard or soft? Can you correct vision with them, and how young can kids get them?
Sorry. Why don't you answer? Because we have a parent, so this is. You go ahead.
Dr. Jacob.
Yeah.
Yeah. So Julia has them. Have a look at her eyes; she'll show you. But the picture of the little boy was pretty accurate. They're maybe a millimeter or two around the iris. Maybe a quarter. Would you say quarter? I'd say more like a nickel, but we'd have to look. They're hard. If you looked at the cross-section of them, unlike a hard contact lens, they're more convex, so they hold fluid. And you have to insert them directly from the bottom at a 90-degree angle because they have to be full of saline. And then the eye's bathing in saline the whole day. So was that all four? Can you correct vision with them? Yes, you can correct vision with them. And they improve light sensitivity like crazy. Julia does herself. Yeah, she does them herself. When she was at BFS, she was the youngest one to ever do it herself at 6.
Yes, some kids can't cooperate. We don't even succeed in fitting them or training them. Sometime between age 6 and 14, we can succeed. Whether or not the parent or the child applies and removes depends on a lot of different things, but we really like it best if the child, the patient themselves, is in charge. They tend to do better. And often we will have kids who can manage on their own between 6 and 10. Typically in the preteen years, we push pretty hard to shift from parent to child.
I can't get my daughter to use a lot of eyebrows.
She does it herself?
No. She won't let it play.
Near the others? Yeah. Well, we've seen We've seen all variations, and we usually find a way to work with the kids. And sometimes they have to come back more than once so we get to know each other. But usually we succeed. We see a lot of other conditions that cause severe dry eye in adults and kids. And we have the time and the bandwidth to spend with the kids to get there.
Matthew has the Froze lens, and he did it as a teenager. So, I mean, it was a steep learning curve. It was like you didn't get it, and then you got it. You know, so it's kind of like that. You just have to keep trying, and I would recommend going to Boston Sight Foundation. There's one place on Long Island, there's a place in the city, and I think going back and forth to do it is very, very difficult because they have to send the lenses out back to Boston to get made. You know, so you have this in-between wait time, whereas if you're in Boston, they make them, they didn't fit, we'll make another pair right there. You can try them, you know, so they really, really work very, very hard. When we were there, there was one woman, she told my made pair. I mean, they work very hard to get a perfect fit on them. And really the best way to do it is to bite the bullet travel there. They're wonderful, wonderful people to work with, and because it's quite a learning curve to do.
It's about a week, right?
Actually, we told families with children to plan for 2 weeks.
2 weeks.
We want you to have the weekend on your own so that we can deal with what was difficult when you return on the Monday. Sometimes people come for a week and then come back. We like to tell people 2 weeks to plan for it. And we do have a dozen centers around the country. They don't have quite as quick turnaround, but not everybody lives near Boston or can get to Boston. There are some brochures out on the table out front that list our 12 centers and gives some basic information.
General question. I can speak loud so I don't need the microphone. We live in Virginia, and I understand your mentor, I guess, was in Virginia as well. But we've gone through several eye doctors, and they misdiagnosed, I think, the tissue with what they said was CIN eye cancer. But we've just been in so many wrong paths that I'm more interested in working with eye doctors like yourself that are more familiar with APS. Can you tell me who your mentor is still with?
He's not in Virginia. He's in Long Island, actually. So I just heard about him now. I hadn't actually talked to him in a while. So it was nice to hear. And then the person I think at the NIH, Dr. Bishop, I think? Bishop. Yeah. She's probably got experience as well because she sees many of the patients that go through there. Though there's not that many people who've seen a lot of patients with APS.
There's someone in Charlottesville named Leslie Olsakowski. She's a cornea specialist, but she's very attuned to ocular surface disease. Whether you need to see an adult or it's more as the person willing to take the time to try to sort it through. A patient is difficult to examine. That's really the challenge. And then it's the book knowledge. Do they even know what APS is? But the approach is the same regardless of what the condition is as far as treating someone with dry eye. So you just have to find someone who's interested.
Definitely, they had mentioned the Froze lens several times, so that's a route that hopefully we will
Hi, thank you so much for coming. My daughter has retinal dystrophy, and as far as the ophthalmologist feels that it has been stable. She was diagnosed at 4 months. And she wasn't diagnosed with APS until 3 years later. Do you find most of the eye disorders remain stable over time, or do they?
So the dry eye tends to be worse earlier on, and then it kind of burns out with or without treatment. With treatment, obviously, things I think are better. The retina, when the patients we had looked at, they were all the same. So they didn't really progress. They were kind of, so they may have progressed at some point, but at least for a few visits with the electroretinogram, they didn't seem to change.
Okay, thank you.
You mentioned that corneal scarring is one of the results of APS-1. Is that secondary to dryness, or is it its own phenomenon?
I think it's its own thing. A lot of people have dry eyes. We see them all the time. They don't end up with corneal scarring unless there's infection or breakdown or other process. So the types of scarring that you see are quite unusual, these little lumps. You see them in other adult forms of dryness, for example. You don't see them in kids. So there's probably something else going on. There's this thing about limbal stem cell deficiency, and someone has found that to be the case, but then the eyes don't behave that way, the usual way in other diseases as well. So there's something else going on here. It's hard to read through the lines because all you have are a lot of case studies and case reports, and people document things in different ways. But there is an inflammatory component, so there's a severe amount of inflammation, and then you just treat that with anti-inflammatories. But that's not dry eye. Dry eye is probably happening, but it's happening sort of elsewhere. Yeah. Okay.
Any other questions? Well, thank you, David and Dr. Ali, for coming here. And
Thank you.